I would like to invite our chairperson, Dr. Naresh Babu, to come and show you certain videos on subretinal gliosis and unorthodox approach for the removal.
Check. Thank you, viewers, and thank you, chairpersons. So we'll be having straight away two videos. This is my disclosure. So we all know that subretinal gliosis is quite common in case of chronic retinal detachment, and that hinders the the settling of the retina.
Everyone. Here we
So
show
what we do in
making
this case
three
is
ports
usually
in
you
the
go
pars plana
a
region.
minimal vitrectomy
A
is done. In
complete
this case, it's a
vitrectomy
case
was
of a
carried
chronic
out.
retinal detachment. You
During
can
the
see multiple
vitrectomy,
subretinal
an
band
extensive
under the retina,
subretinal
which is
gliosis
obscuring,
could
and
be
there is a
noted
pre-retinal
in
band
the
also.
nasal region
So in
and
this case, we
around
have
the
done
disc.
very less
125
vitrectomy.
gauge
So another
port
clue is
was
don't do
introduced
complete
to the
vitrectomy
subretinal
because
plane
that will
at a
settle the
distance of
retina. So
10
make it
millimeters
so,
from the
and
limbus,
between
keeping the
10
trocar
to 12
15
millimeters
degree.
posterior to the limbus. A new valve the cannula, 25 gauge is preferable. Insert the cannula under the retina and in the subretinal space. Use a max grip forceps. Engage the the subretinal band. Just remove it. And this is a very easy way to approach. There is no retinotomy, thereby the migration of the PFCL under retina is
With the
mostly
help
avoided.
of a max grip
And
forceps
even for the
and
nasal
with
or the
vitrectomy
temporal, if
cutter,
you go temporally,
all
you
the
can reach
subretinal
any of
gliotic
these
bands
areas because
were
the
removed
forceps length is
via
quite
the
long.
fourth valve
So this is
port.
the second band
Finally,
which we have
the
removed, and there is a
napkin ring-like
napkin ring
band
around the disc. This is
was
the one
also
which is
removed.
very difficult
The
when we are
final
removing
outcome,
because we have to do a
after removing all the
retinotomy,
subretinal bands
and that leads to the
meticulously,
migration of the
was
PFCL.
encouraging.
Once this is done,
Rest of the
now you can
preretinal
inject the
PVR
PFCL,
bands were
settle
removed
the retina,
via the
and the
conventional
preretinal,
pars plana ports.
gliotic tissues can be dealt with in a conventional way. So this is a case where you can see the preretinal fibers, gliosis. Under the PFCL, just you can scrape with the tannels, or you can directly pick with the forceps. You can see the membrane coming off.
The preretinal membrane
And in
over
most
the
of these
foveal
cases,
region
we stain.
was
This is the
meticulously
preretinal
dissected
gliotic membrane
using a
which is
tannus.
removed. And in almost all these cases, we stain under the PFCL with the blue, and we peel the ILM. Once it is done, usually these cases we go in for two-stage. In the sense, it is filled with PFCL, topped up with silicone oil. We leave the silicone oil for 10-15 days, maximum of 15 days, and then after that you will release that
any
with silicone
undue
oil during the
traction
fluid air exchange.
and for
Okay,
settling the
so
retina adequately.
this is the one which I was saying. The other technique is because it's
Hello everyone.
a blind procedure. Many people think that you will be having bleeding, will be entering into the retina. So in that case, you can still go for visualization. So this is another case of gliotic tissue. Very minimal vitrectomy is done so that you can have good scaffold. The retina will not settle. Once this is done, in the suprachoroidal, subretinal space, you can enter with a 25 gauge trocar cannula. So you don't enter completely. Yes, just you place the cannula, wait for there, then go with the light pipe. Now you can see what's happening inside the eye. You can see the trocar and the cannula inside. Then you gently insert so that you will not be hitting the retina and will be inside the space. So this is more visualized procedure. So you will not be having any adverse event. Once this is done, then you can use the same max grip forceps. Enter into the subretinal space. You can identify the membrane, just peel the membrane, it comes off in toto, and you don't need to do the thing. So here we have to give the credit to Robert McKimmer, the man who did the vitrectomy, and this technique was done by him way back in 1980s when there were no visualization system, no hi-fi system. So this is the modified version of what Robert McKimmer has done way back in 1980s. So you can find, we peel the membrane in toto. Once it is done, as usual, in this case I am now inserting the flute needle in the same space. I want to drain the fluid without making the retinotomy. So this is another advantage which we have started doing now. So I have used a chandelier light also. So this is the fluid, flute needle under the retina to drain the subretinal fluid. In order to make it complete, in one of the port I put the chandelier so that I can go for bimanual. So through the cannula, you go with the flute needle. Now you inject the PFCL, and whatever the excess fluid in the subretinal, whatever fluid there in the subretinal space, it is drained through the flute needle So without making a retinotomy. So I don't need to do any drainage retinotomy in these cases. Once the retina settles, just remove the preretinal glue. I think it was quite tough, so we have to go for again scissors and the forceps, and peel after staining with the BBG under the PFCL, you peel the membrane. So in case if the patient is having a subretinal gliotic membrane, it's very easy to go under the retina and peel rather than making a retinotomy, especially if the patient is having a napkin ring, because there we'll be making a hole adjacent to the disc, and if the retina is not settling, and there is every possibility the PFCL will migrate under the retina, and if it stays under the fovea, it is a real painful thing for the surgeon to see it on the POD1. So with this, I would like to thank the organizers for the opportunity, and I would like to conclude. Would like to take any questions if it is there. Thank you.
Dr. Naresh, that was a super excellent portrayal of how to think out of the box, think out of the eye, and go in and remove the subretinal gliotic bands. The surgery was really nice because it removed all the bands so effectively. But tell us, how did you think of this?
No, no,
Did you think out
I
of
have
the box?
already told. I have not done anything new. Now I started reading all the old articles of 80s and 70s. So many things which I am doing, which is appearing novel, were done. As I told, this procedure was done by Robert McKimmer himself in 1980, and he has published it. It is there in our literature. But only thing is, he has done that in the retinal surgery, not in the vitreous surgery. So he has, with the indirect, he has gone under the retina and picked the membrane. Now with the sophistication, we can modify, and we say, and because thanks to Robert McKimmer, we won what you call a travel grant of $2,500 US for this video. So the credit goes to Robert McKimmer, not to me.
And what about the risk of bleeds, choroidal bleeds?
Which one?
What
No,
about
no,
the
that's
risk?
what I am saying. That's what I am saying. Like we have done a lot of cases. Actually, it is like draining our subretinal fluid in case of what you call the buccal surgery. 15711, if we avoid, in the sense the clock hours, usually it doesn't bleed, number one. And in fact, that is the point of showing the second video, where you can visualize and when we are entering, so that you can see it is it's a smooth procedure. So no bleeding as such happens in these cases.
Any other questions from anybody? Welcome, Paritosh.
So while
Soumya.
removing the membrane, do you do the spaghetti technique? Like, do you twirl the forceps, or you just
No,
pull
no,
it
like
out
that,
straight? You don't need
what you call rolling like a noodle, it is mandatory in case of when we make a retinotomy. In this case, you gently pull it, or you can use the tanners also under the retina, and you can scrape so that the membrane gets released. And when we pull, you would have seen actually it doesn't create
Nothing
any
happens.
problem. It comes off easily. It's not that densely adherent to the retina. Yes, sir. Yes. So as I have told, don't do much vitrectomy. In fact, nowadays I don't do vitrectomy at all. First, to tackle the membrane and do the vitrectomy, so that when there is a vitreous, it is not allowing the retina to settle. That way, it's fine. And in case if the retina is shallow, we can do one more thing: make the port, and through the port infuse the fluid so that the retina becomes much more bullous, and then you go and approach the membrane.
Have you used something like sodium hyaluronate or under the retina to create that increase?
Healer, no, sir. No, 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 no. I think removing healer will be very difficult. But as I have told, we use this same port for draining the subretinal fluid also. Maybe, as you said, in future we can try actually injecting Helon.
In all these cases, do they come out like the way they came out in the first case? One linked to the other linked to the other. It just came out as one kind
Yes.
of complete sheaf, you know.
Yeah.
So normally it is like that, or many a
Yeah,
times
it
you
is
have to go in
normally
and-
like that actually. I am not saying this because just I am doing that. It is a very simple procedure. In fact, it's very gratifying also. So it comes in total. Should not an issue actually.
Thank you, Dr. Naresh. It was a real visual.